Okay. Good morning. Good afternoon, everyone. How are you today? Welcome back to the AURC pre-event series webinar, Road to AURC program in UA Congress 2024. Okay. In this week, it is last week with topic renal transplant actually, but because in the third week there is one presenter, Dr. Hamza, was unable to present his cases due to the unavailable reasoning. So in this week, we give him opportunity to present his cases. Same with previously for the renal tumor cases, there are three panelists: Dr. Penta Kurnia Saputra, Dr. Thomas Yu, and myself. Okay, Dr. Kurnia Penta Saputra. He is a senior consultant urologist with specialty urology oncology, renal transplant, and laparoscopic surgery. Dr. Kurnia Penta is a medical staff in Department of Urology, Medical School of Brawijaya University, and currently he head of urology residency program in the Medical Faculty of Brawijaya University, Dr. Saiful Anwar Hospital, Malang in East Java.
Thank you, Dr. Yudiana.
Okay, how are you, Dr. Penta?
I'm fine, but today I still move to Palembang. I'm on the way to Palembang.
Okay.
No
Okay.
problem. I can follow you.
Okay, thank you, Dr. Pentia, for your willingness in this week's second panelist, Dr. Thomas Yuan-Su. Dr. Thomas is a member of Taiwan Urologic Association. Dr. Thomas is senior consultant urologist with subspecialty oncology urology, endourology, laparoscopic, and robotic surgery. Dr. Thomas currently he's chairman in division of urology, Taipei City Hospital, and chairman in the Department of Surgery, Taipei City Hospital, Renal Branch. Dr. Thomas Yuan-Su, also he will be a local organizing for the UA Congress 2025 in the Taiwan. How are you, Dr. Thomas?
I'm good. Good afternoon, everyone. It's great to see everyone here.
Okay, thank you, Dr. Thomas, for your willingness of this day. And the second panelist, myself, I'm Wayan Yudiana. I'm a consultant uro-oncology at Profesor Ngurah Hospital in Denpasar, Bali. Okay, I introduce the presenter for the renal tumor cases, Dr. Kaudri Hamza Sawar, right? Dr. Kaudri?
Yes.
Okay, Dr. Kaudri or Dr. Hamza from the Pakistan Association of Urologic Surgeon. He will be presentation with title topic renal cell carcinoma with tumor thrombus in inferior vena cava extending to the right atrium. Okay, Dr. Hamza, for the shorter time, the time is yours. Please.
Thank you. Ji, can you hear me?
Yeah, clear.
Good afternoon, everyone. First of all, my sincere apologies for not delivering the presentation last week. Um, Talking to my introduction, this is Chaudhry Hamza Sarwar, resident at Sheikh Zayed Medical Complex, NIKD, Lahore, Pakistan, and representing PAUSE. I'll be going to present a case of complex renal tumor with thrombus extension through IVC up to right atrium. A 38-year-old housewife, resident of Lahore, married with 4 children, was referred to us for definitive management of her symptoms. Her presenting complaints were pain in left flank region for 1 year with off and on radiation to back. There was 1 to 2 episodes of hematuria and significant weight loss. She was non-smoker and there was no family history of any tumor. On general physical examination, she had a thin, lean build and was paler on inspection. Abdominal examination showed a non-tender mass palpable in left flank, firm to hard in consistency with smooth surface and regular margins of about 15 centimeter in size. Her baseline investigations showed low hemoglobin level as well as albumin. Total leukocyte count and platelet count were normal. Renal function tests were within normal limits. Urine culture and sensitivity showed no growth. CT chest, abdomen, and pelvis with IV contrast was done, which showed a 14.6 into 9.7 into 10.9 centimeter exophytic heterogeneously enhancing mass involving the left renal lower pole with internal foci of calcification, as shown in these axial films. There was contiguous extension of tumor thrombus into the left renal vein, extending into the IVC, with interval increased extension of the thrombus reaching up to opening into right atrium. So the radiologically, the TNM staging was T3C N0 M0. You can appreciate the tumor thrombus in IVC extending into the right atrium, as shown in this image. CT pulmonary angiogram was done, which also detected lesion in right atrium. The patient was diagnosed with left renal mass along with thrombus extension through inferior vena cava up to right atrium. She and her attendants were counseled regarding treatment, complications, and prognosis. She was optimized before surgery. Multidisciplinary approach was used with the help of hepatobiliary and cardiothoracic departments of our institute. Surgery was performed on 16th of May, 2023. Chevron in CN was given along with right anterior mini thoracotomy for tumor thrombosexcision and left radical nephrectomy was performed. The thoracotomy in CN was given just below the submemory fold on right side, and it starts from just adjacent to sternal border. And it was given in 5th intercostal space, a horizontal in CN. Here are some pictorial images which were taken during surgery. You can see the exposed kidney and tumor, renal artery being ligated in the middle image, and devascularized tumor. Liver was mobilized to expose inferior vena cava. You can see the right hepatic vein being clamped and fully exposed inferior vena cava. Thoracotomy was then done by cardiothoracic surgeon to expose the right atrium for thrombus retrieval from atrium and superior vena cava. IVC was then repaired with Proline 40 suture. You can see the resected specimen and wound closure. 2 drains were placed, one in pelvic cavity and other one in thorax. The surgery went successful and she was shifted to ICU for post-op care. Extubation was done within 24 hours. Post-op recovery was uneventful. Post-op echocardiography showed no remaining tumor thrombus in heart. As we have no facility available intraoperatively for transesophageal echocardiography, so it was done post-operatively on bedside. The patient was discharged after full recovery on 26th May 23 with regular follow-ups advised. And she is still on our regular follow-up every 3 monthly. Whenever she comes in our OPD, we perform ultrasound KUB, routine baselines, including CBC, renal function test, and LFTs. And all this test appears normal each time. And she is living an ordinary life with her children. Here comes the lucky patient after surgery. Histopathology report came after 10 days, which showed that it was a clear cell renal cell carcinoma grade 3. Lymph nodes which were sent separately were negative for metastatic carcinoma. The coordinated efforts of a multidisciplinary team facilitated the successful management of a complex RCC case with significant vascular extension, demonstrating the importance of comprehensive diagnostic and therapeutic strategies. Thank you. You may proceed with question and answers.
Okay, thank you very much for your nice presentation, Dr. Hamza. Okay, there is a true of complex renal tumor with multidisciplinary approach for the renal tumor and tumor thrombus. Okay, the first opportunity I give to the Dr. Thomas, maybe, please, Dr. Thomas. Your assessment, feedback, or vision for the Dr. Hamza. Thank you.
Congratulations for the successful operation. And it is really a rare case with extension to right atrium. Can you hear me? Can you hear me?
Yes, I can.
Okay. So I'm still in the annual meeting conference room, so it might be a little bit noisy to audience. Sorry about it. And my question is, do you try to use instead of chevron incision, do you think to retrieve all the tumor thrombus from the IVC incision rather than open the right atrium to perform a dual opening surgery for this case?
Sorry, I couldn't understand your question.
My question is, do you try, since you have exposed the whole IVC, is it possible to open the IVC only to retract all the tumor thrombus from IVC from below, rather than to remove all the thrombus from right atrium?
Actually, it was difficult to remove the tumor thrombus by opening the IVC. So we take the help of cardiothoracic surgeon so that to expose the right atrium and then remove the thrombus, the part which was in the heart.
Okay, thank you. Because in our experience, the tumor thrombus will not adhere. There is not much dense adhesion between IVC, the wall of IVC, and the tumor thrombus. So in our experience, we can remove the tumor thrombus from the IVC. In a circumferential maneuver, then we can remove it clearly. This is why I asked this question. Thank you very much.
So in this case, we tried to milk off the tumor thrombus, but it was difficult. So we take the help of cardiothoracic surgeon, which were already on board for the surgery.
Okay, thank you very much. Thank you.
Okay, thank you very much, Dr. Thomas, for your question and feedback. Now, give opportunity to Dr. Penta, please. Dr. Penta.
Thank you, Dr. Yudiana. First of all, I have a comment. I think that this is the challenging operation with a difficult case, and I appreciate with the operation. I have two questions. The first one is there any place for the targeting therapy before the surgery?
No, sir, we didn't give any conservative therapy.
Okay. And the second one is so the incision is chevron, yeah? The big incision, and but the extubation is on the first day after the surgery. I think it's very risky for the breathing of this patient. You know what I mean? Because of the pain of the abdomen, usually make the decrease of the breathing, and the patient painful for the breath. Take a breath. So what do you comment about that?
So we keep the patient pain-free post-operatively. Actually, we are not having good experience in laparoscopic nephrectomies. We just perform laparoscopic nephrectomies for simple non-functioning kidneys, not these huge tumors.
No, I
and
mean,
also
I mean,
the patient.
Your incision is big, yeah, it's very big incision.
Sir, but
so
for
left to the
proper
left.
exposure.
And how the inspiration of the patient for the breathing.
Yes, sir.
Because your extubation on the first day after the surgery.
Sir, I do agree, but for proper exposure, we were forced to give that much insulin to mobilize the tumor, kidney, as well as IVC.
And the second one, I have, so the incision is just saffron, yeah, without do the thoracotomy on the cut the sternum, without cut the sternum, yeah.
Yes, sir.
Just only the saffron, and the cardiothoracic surgeon mobilize the atrium from the incision, the saffron incision, yeah.
Yes, sir.
Okay, so I think it's good. Thank you, Dr. Yudiana.
Thank you, sir.
Okay, thank you, Dr. Penta, for your question. Okay, and for me, I just confirmation is the thrombus separated in inferior vena cava and in atrium, right atrium, or the thrombus is like a fusy, united from the vena cava until right atrium.
Sir, after exposing the atrium, they milked down the tumor thrombus below into the IVC, and then it was retrieved from the incision which was given on IVC, and then IVC was repaired afterwards.
Okay. I'll give the patient like anti-coagulant with heparin maybe
Yes, sir.
operative, yeah.
Sir, we also given him systemic anticoagulation was maintained using heparin intraoperatively.
Okay, and during the surveillance, what do you attention for this patient? Because maybe there is like oligo metastasis from the inferior vena cava thrombus. Is there any metastatic, distant metastatic during the surveillance for this patient?
No, sir. Care was taken to avoid fragmentation during retrieval of thrombus, and we confirmed it post-operatively through echocardiogram for any other tumor, remaining tumor thrombus in the heart.
Okay. Thank you, Dr. Hamzah. Dr. Thomas, Dr. Penta, is there any question again or feedback again for Dr. Hamzah presentation of case?
It's enough for me.
No, thank you. No, thank you.
Thank you, gentlemen.
Okay, thank you very much, Dr. Hamzah, for your presentation and complex renal tumor cases. Thank you, Dr. Penta and Dr. Thomas, for your willingness just one presentation in this day. Okay, thank you very much, Dr. Penta. Safe life, safe life, Lemang and Dr. Thomas, for your comprehension today. Okay, thank you very much, everyone, and forward for the main session with the renal transplant topic. I give my friend Dr. Diandra to guideline this session. Dr. Diandra, please. Thank you.
Yes, thank you, Dr. Wayan, Dr. Thomas, and also Dr. Penta, and the participant as well. My condolences for Dr. Hamzah's grandfather who passed away last week. That's why we're giving him the chance to present today as compared to last week. So my condolences, Dr. Hamzah. So for our next session, it's going to be the last session of the entire pre-event program that we're going to have. This is the last pre-event session of AURC before all of us can meet in person in Bali. So for today's, we're gonna have, well, it's scheduled to be 3 presentations, but unfortunately, one of the participants from Bangladesh is having difficulty because of the political condition there currently. So he's not able to gain access to internet. And also, most probably, he will not be joining us in Bali. So hopefully, everything will commence and you know, be sorted out as best as they could. So today we're gonna have 2 presentations instead, and we're gonna have 3 panelists. For this opportunity, I'm going to be the moderator, and then we're going to have 3 panelists. So let me introduce you to all of our panelists for today. First, we have Professor Phon Min from Myanmar. He's a retired professor of urology at the University of Medicine, One Yangon in Myanmar. And he's also the past president of Nephrology Society in 2020 and 2021. Hi, Professor Phon.
Hi, Mr. Tara.
Hi, how are you?
Fine.
Okay. Okay, thank you. Thank you for joining us today.
Sure.
Okay, and our 2 panelists here is actually both of them are my senior, one of the rising stars of transplant in Indonesia. First, I want to introduce you, Dr. Gerhard. He graduated PhD from Institute of Cellular Medicine, Faculty of Medical Science, Newcastle University. Has multiple research and patents in both renal transplant and kidney urology field and pediatric urology field, and subspecializes in kidney transplant and pediatrics. Currently, he's working at Cipto Mangunkusumo Hospital and Carlos Hospital in Jakarta. Hi, Dr. Aldi, we called him.
Hi, Dr. Diandra and Professor Min. It's a pleasure to meet you both.
Okay, and our last panelist for today is Dr. Pandey Made. He graduated PhD, same place as Dr. Gerhard as well, at the Institute of Cellular Medicine, Faculty of Medical Science in Newcastle. He subspecializes in kidney transplant and laparoscopic urology, and is currently full-time academic and clinical staff at Universitas Udayana Teaching Hospital in Bali. How are you, Dr. Pandey?
I'm pretty good. Thank you, Dr. Diandra. Hi,
Okay,
Professor Min,
thank you.
Dr. Aldi, and everyone.
Thank you, Dr. Pandey. So because everyone's here, probably we can start our first presentation. Dr. Anika. Please, Dr. Anika, the time is yours. There's going to be a presentation and a question and answer afterwards. I encourage all the participants here to ask as much as we can, and we will discuss it within the time frame. Thank you. Please, Dr. Anika.
So good afternoon, everyone, and thank you to panelists and moderator for giving me a chance to present my case. My case title is Post-Renal Transplant, Ureteric Obstruction, and Early Management is Essential. Regarding my introduction, I am Anika Said. I am final year urology resident at Aga Khan University Hospital, Karachi, Pakistan. So my case is of 47-year-old gentleman who is known case of hypertension, and he has a history of renal transplant 2 months back, and now he presented with complaint of graft side pain, nausea, vomiting, and anuria. All of these complaints were there for last 24 hours, and he had no other associated complaints like fever or anything else. His past medical surgical history include history of renal transplant to right iliac fossa. That was 2 months back, and the donor was his brother. And he take valsartan for hypertension, and on post-operatively he is been on tacrolimus and MMF for as a prophylactic for immunosuppressant for transplant rejection. Post-operatively, he had uneventful recovery and he achieved a baseline creatinine of 1.2. And his family history is positive for end-stage renal disease due to glomerulonephritis. So based on this assessment of the graft site pain and urea, our initial assessment was either it's ureteric obstruction or some kind of graft rejection. It's acute graft rejection because he's being presented in 2 months. So we investigate this patient on the lines of these two assessments. We got done his baseline investigations, which include hemoglobin or hemoglobin was within normal range. Creatinine was raised of 3.5 and potassium was also raised, which was managed with conservatively. An ECG was done and the cocktail was given. So this means that there's some kind of renal insert. It is either it's obstruction or it's AKI or transplant rejection. So we got an ultrasound color Doppler of graft kidney, and ultrasound color Doppler suggests that the patient has a good vascularity in kidney in the graft, and the peak systolic velocity and everything was adequate. And but there was hydronephrosis of the graft kidney and hydroureter of the graft kidney, as it's mentioned on the images. So after this ultrasound, so that was one thing clear that it's kind of some obstruction because the renal velocity and the perfusion was good. Resistive index was also good. So we got a CT KUB, and on CT KUB, here we can see that there is this swollen kidney with hydronephrosis and hydroureter. So my screen got freeze. Just give me a minute. It's just a video. So
Dr. Annika, did you send us the presentation?
yes, I did send to Missy.
If yes, probably we can help whilst you're please still present, and then we'll try to open your slide from our side, and then you can continue on with the presentation. Missy, are we able to open Dr. Annika's slide? Dr. Missy? Or you can retry to share it, probably.
Yeah, I'm trying to share it. Just give me a minute.
Okay.
So don't run the CT, it will stop again. So here we can see that there is this hydronephrosis and the hydroureter and with the swollen kidney. So next slide. So based on this assessment, right-sided percutaneous nephrostomy tube was placed and nephrostogram was done, which showed dilated callus, pelvis, and the ureter. And there's this press the next. And there is this stricture at the 1 centimeter stricture at the ureterovesical junction at the anastomotic site. So keep pressing the nest because so after PCN placement, his creatinine got normalized from 3.2 to 1.2. So So after PCN placement, he was kept on the PCN for 1 week, and then endoscopic treatment was planned, which was balloon dilatation and the DJ stenting. Here we can see that there is this PCN in place and the stent was placed, and intraoperatively retrograde balloon dilatation was done, and there was very small stricture, even it's less than 1 centimeter, and stent was placed. So PCN was removed on the next post-operative day, and the stent was kept for around 4 to 6 weeks. And after the stent removal, on his follow-up, 1 year after his follow-up, he again presented to have complaint of increased creatinine, and this time creatinine reached 2.8, and then CT urography was done, which shows there is this stricture at the same side, and the CT urogram showed that there is no contrast going into the bladder. So this time, definitive treatment was done. That is ureteric reimplantation. Intraoperatively, it was around 1.5 centimeter stricture at the anastomotic side, and the ureter proximal to the stenotic segment taken and reimplanted into the bladder through leech-Krieger's technique. Extravesical anastomosis was done. Patient has uneventful recovery, and he was discharged on the second post-operative day. 1 drain was placed, that was removed on the second post-operative day, and the stent was removed after 4 weeks. And currently he is doing well so far. His baseline creatinine is 1.2, and all of his parameters are within normal range, and he's taking immunosuppressant as regular, that was advised before. So possible risk factor for uterus stenosis, that could be the early stenosis that present within 3 months, and that could be the late stenosis that present after 6 months. For early stenosis, the possible risk factor are the surgical techniques, compromise, or there could be the compromised ureter blood supply, and the late stenosis causes are fibrosis, infection, rejections, BK virus, and any vascular disease. So even AU guidelines recommend PCN placement for urgent PCN placement for kidney decompression, and to diagnose stricture diagnosis, we integrate pyelogram. And according to guidelines and according to literature, small stricture can be managed endoscopically, but there is high chances of failure, like 50% chances of recurrence. And late stricture or stricture that are greater than 3 centimeter or that recurrent on the endoscopic treatment should be managed conservatively with the definitive repair, that is ureteric implant. So take-home message is early diagnosis and urgent diversion to the kidney to prevent the graft failure, and an early diagnosis, and initially we can do endoscopic and then the definitive repair. Thank you.
Okay, thank you, Dr. Anika. You just good timing for your presentation. Please, I invite Professor Min first to give his comments and questions.
Yes, first of all, congratulations to Ms. Anika and for your good job as well. So in that case, the possible cause of ureteric obstruction could be the shortage of vascular supply. This is, I agree. But did you do any rejection workup before deciding that this is the other vascular cause or any other infection or fibrosis?
You mean prior to transplant?
No. What I mean is that before you're correcting the ureteric stricture, so because one of the possible cause of the rejection is one of the possible cause of ureteric obstruction is rejection. So in that case, I find that this is the obstruction is undeniable. What I want to know is, did you do any rejection workup before you were setting up for the ureteric obstruction correction?
No, sir, we did not do any workup for that, as the ultrasound was clearly suggesting that the patient had the good renal flow. So we did not proceed ahead for any workup.
Yeah, sure. That is a good answer. And then your stricture segment is quite long. And then there might have a subsequent chance of having vascular compromisation and also subsequent cause of ureteric obstruction. In that case, what are the other options that you can correct the ureteric stricture?
I can only think of ureteric reimplantation.
In my experience, I use Worry Flap.
Body
when we
flap,
need
yes.
to
If the
resect,
segment is long, yeah.
yeah, lengthy ureter, we need to resect lengthy ureter. I did the body flap repair, and in case we can use the native ureter as well.
So yeah, we can think of ureterostomy and ureteropilostomy if there is a recurrence, and as you mentioned, the body flap. But so far there is no recurrence, and at that time the stricture was not large enough that we could proceed with the body flap. That was very well managed on the reimplant.
Okay, thank you. Thank you, Ms. Anika, for your presentation.
Thank you,
you,
sir.
Professor Min. Dr. Aldi, do you have any comments or questions?
Yes, thank you, Dr. Anika. I hope you can all hear me, sir.
Yes,
Dr.
sir.
Anika, I agree with Professor Min. I think vascularization can be the major problem in this case. How would you prevent this from happening in your subsequent case, Dr. Anika? Are there any tips and tricks that you should consider in doing ureteral reimplantation kidney transplant to prevent this from happening?
So adequate tissue handling, and there should not be very much kinking or stretching of the ureter during the anastomosis. That could cause the further necrosis and the ischemia of the ureteric segment and can lead to the stricture. And we can also prevent it by putting a TG stent in those cases where there is where we can think of the possible ischemia if the tissue is not healthy enough, if the tissue is fibrous, or if the tissue is kinked, or and I tissue handling and the stenting.
Thank you. I think tissue handling is definitely very important. Did you use DigiStent frequently or regularly in your center?
Not
No.
regularly,
Okay.
not regularly, but only in the cases where where we can think of the ischemia, or where the ureter is short or the narrow, or that in only those cases we presented, we put the digestion, otherwise we don't.
Yeah, we use double DigiStent regularly in our center. We have no problems regarding the urinary tract infection, but we found it very helpful in our center. And the other things that we always do is to make sure that the golden triangle, so the fat between the inferior calyx and the ureter remains intact. So make sure that our donor team, especially during the live donor nephrectomy, does not really interfere much with the fat and in the calyx inferior. The other things, and that some publications has published, is that to make the spatulation really big, some publications recommended 2 centimeters to 3 centimeters spatulation, and to partially stitch or reconstruct the detrusor muscle. So instead of having all layers during the detrussorrhaphy, you only do a partial detrussorrhaphy. Some publications show that they reduce stenosis cases. That's, I think, my tip. Thank you.
So I agree with your point of golden triangle preservation, just to preserve the periureteral tissue. But we don't put the digestent in all cases, but we do take care of the golden triangle and the periureteral tissue.
Okay, thank you for the tips and tricks, Dr. Aldi. I think all the participants here learn a lot about that, especially the tissue handling and the golden triangle as well. Dr. Pandey, probably, do you have anything to add or any comments or questions?
Right, thank you, Dr. Diandra. I totally agree also with Professor Min and Dr. Aldi also. This could be not only the surgical problem, this might be also about the rejection problem also. That's why we have to address that. Actually, I have the same question with Dr. Aldi, actually. So what we have to do before, intraoperatively to prevent the urethral stenosis or urethral stricture. Okay, because that's already asking by Dr. Aldi, I have another question. Previously, you present about the all the risk factors based on the theory, and then is that also apply in your case? I mean, all your risk factor, have you evaluated that in your case? And what is the results based on the theory on the risk factors?
So the possible risk factor that was in my case, that because it presented very recently after the transplant, so we thought of the like compromised handling or the compromised blood supply, but we did not evaluate the other risk factor like infection, rejection. That is out of place because the rejections usually happen late, and the infections, the PK virus, and so we only evaluated on the line of the tissue handling, but we did not evaluate any other risk factor. If that case was presented late, like after 6 months, 1 year, so we could think of other factors and we would definitely evaluate that.
Yeah, thank you, Dr. Anika. Also, in line with Professor Min, also in our hospital, we have the same case also with Dr. Anika had with this one, and we do body flap also. We try to reopen and then re-anastomosis and do the body flap also.
Yeah.
Thank you, Dr.
Because
Anika.
we cannot
totally
assess
agree.
the extent of ischemia. We cannot assess it very well. That's why I take the safer way to do body flap.
Yeah, that was always
same
a good
also with
option.
our case, Professor Min.
If you're not sure about the vascular, then don't, because doing the next operation can be very, very difficult, very challenging.
Yeah.
So do you guys proceed for endoscopic treatment initially, or just proceed ahead with definitive treatment on the like upfront?
To be honest with you, even in late cases, I always try to use endoscopic approach first, because I think most of our patients prefers that way. It takes time to sometimes convince them that re-operation is the way to go. It's the only way to go. So I can either put the stent. Very rarely I can put it retrogradely, but most of the time I think antegrade approach is usually better, since you have already the nephrostomy access anyway.
Yes.
In my case also, I try to put the double J stent, but it was unsuccessful. So that's why we try to repair it straight away. Yeah,
I agree with both of you, because the retrograde GG stenting is very difficult when we cannot access the implantation site. That is why antegrade GG stenting is preferable for me. Thank you.
Okay, any other addition from the panelist or the presenter? Okay, otherwise we're about out of time. So I would thank you and congratulate Dr. Anika for presenting her great case for us to discuss today. Thank you, Dr. Anika. Okay, we're gonna move on to the second presentation by Dr. Yang. He's gonna present about early recognition of a possible bleeding post-renal transplant. Dr. Yang, the time is yours.
Hi, good afternoon, everyone. Thank you for the opportunity to present a case on early recognition of possible bleeding post-renal transplant. And this is a case that was done in Singapore General Hospital. And I'm one of the senior residents representing Singapore Urological Association today. So to introduce our recipient for this case, this is a 54-year-old Chinese male with significant history of ESRF, secondary to concentric IgA nephropathy. So he was diagnosed with Henoch-Schönlein purpura in 2010. Initially, was treated with prednisolone. However, subsequent renal biopsy showed that there was IgA nephropathy, which progressed to concentric IgA nephropathy subsequently. And he became ESRF in 2016 and started on hemodialysis in 2017. And pre-transplant, he was producing about 100 ml of urine a day. The deceased donor was a 60-year-old Chinese male, and the cause of death was intracranial hemorrhage. And this was a case of a donation after cardiac death. The right kidney was used for implantation. It had 2 renal arteries and 1 renal vein. And post-implantation biopsy showed Rimusi score of 3 out of 12. In terms of bench work, the renal vein was lengthened using the cava with running proline 6O, and both arteries were on a single Correll patch. Intraoperatively, we did a standard end-to-side arterial and venous anastomosis to the external iliac vessels, and patchy slow perfusion was seen initially on releasing the clamps, but the kidney was fairly turgid and there was good homogeneous perfusion later on. However, there was no urine seen on table. Ischemic times were first warm 21 minutes, cold ischemia 11 hours, and second warm ischemia 21 minutes. And the total operation duration was 2 hours and 35 minutes. And the patient's pre-op hemoglobin level was 12.6. So the operation ended at 12:50 p.m. and the perfusion scan was done at 4:14 p.m. which showed pooling of contrast in the right iliac fossa, as you can see in the diagram here. There's extravasation of the radial tracer at the right iliac fossa. The abdominal drain at that time was hemoserous, it was not bloody, and the hemoglobin done at 4 p.m. was 11.7, so there was a 1 unit drop of hemoglobin. So the patient was sent back to the operating theatre emergently for graft exploration at 5:55 p.m. And we also evacuated the hematoma and achieved hemostasis. So intraoperatively, the graft was pink and healthy. The anastomosis were intact. There were no active bleeders seen. However, there was mild oozing from perinephric fat, and there were 250 mL of blood clots evacuated. Intraoperatively, the patient received 1 pint of PCT and post-op hemoglobin was 10. The patient remained stable thereafter. There were no further surgical issues post-operatively. There was delayed graft function and the patient was put on dialysis on POD 1 to 3. There was also borderline change for acute cellular rejection on renal biopsy, for which the patient was started on methylprednisolone. The patient was discharged well on POD 15 and the nadir creatinine was 154. Post-operative bleeding following renal transplant surgery is a critical concern that requires prompt recognition and management to prevent serious complications. In terms of incidence, it occurs in about 5 to 10% of the renal transplant recipients. And risk factors include vascular anomalies and complicated reconstruction, prolonged surgery duration, high panel-reactive antibodies, and coagulation disorders. And potential surgical sources of bleeding include unrecognized bleeding from the anastomosis, or unrecognized transected renal artery branches, which may happen from overzealous trimming of the perirenal fat. It can bleed from small vessels around the hilar fat, as in this case, and also pelvic or retroperitoneal veins. Sometimes the slip tie from the inferior epigastric vessels, that could be the cause of bleeding. And even calf muscles or drain insertion sites can be sources of bleeding as well. In terms of clinical presentation, early signs include tachycardia, hypotension, and high bloody drain output. Late signs include swelling or bruising at the surgical site, decreased hemoglobin, and signs of hemorrhagic shock. Imaging options, if bleeding is suspected, include ultrasound and CT scan, non-contrasted, which is to look for large collections around the allograft. In this case, the bleeding was diagnosed on renal perfusion scan. So renal perfusion scan provides a diagnosis for post-operative complications and assesses the function of the allograft. In our center, MAC3 renography is the most commonly performed modality, especially during office hours. And the acquisition of the scintigraphic images involves putting a gamma camera detector, which is positioned anteriorly to the transplanted kidney over the iliac fossa instead of posteriorly for native kidneys. And prompt homogeneous radial tracer uptake in the allograft should be observed, and radial tracer excretion into the pelvic calyceal system and ureter should be prompt with no evidence of radial tracer retention at the end of the study. So renal perfusion scan can be used to diagnose vascular occlusion. In a normal transplant perfusion study, radioactive bolus reaches the transplanted kidney at almost the same time as the iliac vessels adjacent to it. However, non-visualization of the allograft in the immediate post-operative setting is suggestive of arterial thrombosis, and almost always the result of vascular kinking or technical difficulty at the time of surgery. Therefore, prompt re-exploration is warranted to restore the vascular supply to the kidney. As you can see here, here is a normal perfusion scan, and you can see this you can see the allograph here. And in this photograph, you can see that there's a non-visualization of the graph in the right iliac fossa. And renal perfusion scan can be used to identify rejection as well. And it typically shows reduced perfusion, diminished uptake, and delayed excretion. And lastly, it also can be used to identify urine leak. So it is seen as a photopenic area which gradually fills with intense renal tracer during the scan, or the absence of excreted activity outside of the urinary tract. However, renal perfusion scan has its drawbacks. The findings are usually non-specific, and the images have relatively poor spatial resolution. So in conclusion, postoperative bleeding following renal transplant surgery is a significant complication that necessitates vigilant monitoring and rapid intervention. And renal perfusion scan is a great tool that provides a diagnosis of postoperative complications and assesses the function of the allograft. Thank you.
Thank you, Dr. Yang, for your presentation. I would invite again Professor Min to give your first comments and questions, please.
Yes, thank you, Dr. Yang, for your comprehensive presentation. And the early blood loss in renal transplantation is a common complication. And then we need to keep in mind that the bleeding might be at an anastomotic site or from the branches of vessels that was latent in the peripelvic fat. Especially for the fat men with the enormous fat load in the peripelvic area, then we can miss such a kind of vascular problem. So in that case, the best prevention is to do meticulous bench surgery to stop every vessels. Yes, and then in case it is the usual for the men that we can miss. Sometimes we can miss the our work. So in that case, you can do the prompt diagnosis, and then you can react very promptly to save the life of the patient. That is a good point. And then the other workup is quite agreeable. And then especially, I would like to mention one point is that for the cadaveric renal transplant donor, we can get the lengthy vascular tree, so that if it is not not bleeding from the major vessels, then the small vessels like the branches bleeding from the branches is quite common. In my practice, I have one such a kind of problem, but we can notice it during the intraoperative period, so that after declamping the renal vessels, there is bleeding. So we can find one small branch like you and we can stop the bleeding from that particular area. This is a good job, and I have no furthermore comment on that, and I agree with you.
Thank you so much.
Professor Min. Dr. Aldi, do you have any comments or questions?
Yeah, thank you, Dr. Yang. I think you did a great job in noticing the bleeding very early. So congratulations on that. We had several cases also bleeding. I think it's inevitable that once you increase the number of kidney transplant, then you'll get such complications. We usually do CT scan using a contrast if needed or non-contrast, because MAC3 is not readily available in Indonesia, unfortunately. I agree, if you have MAC3, that's probably a good option to diagnose. I totally agree with Professor Mind. I think the fat allograft with a lot of adipose tissue can be very tricky. What we usually do is to put a hemostatic aid, like a Surgicel or fibrillar Surgicel that they use in neurosurgery to try to achieve the best possible clotting. Of course, it must not substitute the meticulous blood control that you have to do. But for the small bleeders, I think it can help.
Thank you. Thank you. Thank you.
We had some catastrophic cases, I think, that happens late due to infection. Not some, just one case. That's a good lesson for us as well. But I think all in all, I will be very careful in doing transfusion, Dr. Yang. I don't know in your case whether that's necessary or not, but I'm sure the team at that time already decide what's best for the patient. But in our center, we really think twice or three times before we put transfusion in the patient because of obviously the immunological reason. That's according to our my experience. Thank you.
Thank you, Dr. Aldi. Dr. Pandey, probably you have some questions or comments.
Yes, thank you, Dr. Diandra. Congratulations, Dr. Yang, about the presentation. So we have all the lectures from Professor Min and Dr. Aldi about the surgical aspect. So for this case, also as you mentioned before, your patient had a delayed graft function, and also from the biopsy has a mild, the acute cellular rejection. I just wonder if this case not only due to the surgical aspect, maybe this also mixed between the surgical aspect and immunological aspect. Regarding that, do you know about the immunological status of your patient, basically the recipient before the surgery? How about the the PRA status? Because you said that the risk factor also, one of the risk factor for this case is the PRA status, and also how about the the HLA mismatch between the donor and also the recipient. And the last but not the least, how about the induction therapy? The immunosuppressive therapy before we proceed with the kidney transplant.
Okay, so
Please,
in
Dr.
this, thank you for your question. In this case, it's most likely a surgical cause because it occurred immediately post-operation. So it's unlikely to be an immunological cause for the bleeding. And in our institution, we match the patients very carefully. Usually they are ABO compatible. Yeah, usually match the panels strictly. Yeah.
Yes, thank you, Dr. Yang. One question also from the reoperation intraoperatively. You said there was no active bleeding. There's some oozing from the fat. And then what did you do to stop the bleeding for that? Do you take out some sort of like the fat, or just do the to stop the bleeding?
Yeah, so usually we try to stop any bleeding meticulously intraoperatively, and we also routinely use the adjuncts such as surgical snow to help stop bleeding as well. Yeah, so these are the ways that we try to prevent bleeding in the first place.
Thank you, Dr. Yang. That's all from me, Dr. Diandra.
Okay, thank you. I noticed bleeding, I say, would be quite one of the most common complications after transplant. From the panelists, what's usually your steps if you're, or at least you're thinking about probable bleeders after the surgery? What are your steps of diagnosing the post-operative bleeding? Professor Min, probably you can start.
Yeah, firstly, we assess clinically, and if there is any drops in the hemoglobin, then we use ultrasound. Is there any perinephric fluid collection? Or if we want to know the specific diagnosis, then we proceed to some imaging procedure like radionuclide imaging, MEC3 or something like that. So in that case, MEC3 is not very specific for the bleeding. So it can detect only the perinephric fluid collection in post-transplant period. So in that case, the better one is, if it is feasible, we can do if it is massive, not very massive, we can do the CT angiogram through the CT angiogram to assess the graft vessels. That is one point. And after all, if we find that this is very sure of the hematoma, further reduction in hemoglobin, and also the hemodynamic changes, then we directly proceed to surgical repair. That is my practice in Myanmar, because we have very limited resources to do the other sophisticated investigations regarding the bleeding. So what's your opinion, Dr. Aldi and Dr. Bendy?
Yeah, I think it's we have very similar resources. I think, Prof. CT angio, I think ultrasound definitely is the most readily available tools that we can use, and sometimes we can do it bedside. And then the next is CT angio. Sometimes it's very tricky when patients also have delayed graft function and you're not sure whether or not this is immunological. But again, the hemodynamic status of the patient, we usually put drain in, but drain can be deceiving because drain can be clotted, and sometimes you think that there's no bleeding. That's why you have to also always look at the patient and then perform ultrasound to see whether or not there's a perinephric fluid collection. We rely much on our living donor, so we do a lot of ABO incompatible patients, and those patients usually have plasmapheresis prior to surgery, and this is also challenging. It can create coagulopathy in our patients. What we usually do is to examine the coagulation profile using thromboelastogram, TEG, prior to surgery. That can be useful, I think. So that's what we do. Thank you.
Okay. Probably the last 1 minute, Dr. Pandey, please give us your thoughts on this.
Yeah, I think the same also with Prof. Min and also Dr. Aldi. We rely on the clinical status of the patient and also the hemoglobin drop, and also the first test is the ultrasound, because that's quite cheap, and also we have ready with the ultrasound. If we have the results has abnormality with the ultrasound and also the hemoglobin drop, it's quite rapid. We can do directly with the reoperation without the CT scan before the reoperation.
Okay. Thank you, everybody, the panelists. Thank you, Dr. Yang, for your presentation. I congratulate you. See you all in Bali, hopefully.
Sure,
we can continue our discussions there. Thank you,
Sure.
Professor Min, Dr. Aldi, Dr. Gerhard, Dr. Pandey, and also Dr. Yang. Again, I think these kind of discussions are very, very important in our field, especially in Asian urology. We discussed from earlier before a few cancer cases. We discussed pediatric cases. We discussed stone cases. We also discussed renal transplant cases. I think discussions like this are very, very good for our society. Hopefully, we will have more. This is just the foundation of what we can build going on forward. So I think this is a good exercise to pick each other's brain and also know what others are doing in their center, so that we have more a broader point of view. Okay, that being said, before our closing remarks, we're going to have a Wheel of Fortune. We'll be giving away one tumbler or a coffee bottle for those who are fortunate in the Wheel of Fortune. Please, you can get this tumbler at the registration booth when you are at in Bali for UAA. So please, we can spin it and then we can stop. If your name is up, please raise your hand or chat in the chat box so that we know you are here. Otherwise, we're gonna spin the wheel again. IV Do we have an IV? I don't know if this is a nickname, probably. Do we have anybody here? IV? IV going on once. IV going on twice.
There's someone named.
There's somebody named IV. Okay. Okay. Are they here or are they in the participant attendee group, Dr. Missy?
Yes.
Okay. Okay. So congratulations. I think this is the first time we had the first winner with the first wheel. Usually we have a few of them and then the name come up from the participants who attended today. Okay, so with that, I congratulate Dr. Ivy for the tumbler, and then you can get that on your registration during your registration in Bali. So with that, that concludes actually all of our pre-event. So we try to make this as interactive as possible. We wanted to do something different this year for AURC so that we can get a lot of inputs. We can get a lot of different cases from different centers with different backgrounds and different equipments. I'm guessing, but again, all around throughout Asia. So this is just a small taste of what our discussion might go forward. Hopefully, we can see everybody in Bali. I will like to thank Dr. Sam, Dr. Yudiana as well, Professor Poncho, and all the committee, all the everybody who works hard, Dr. Missy as well, and everybody who works very hard to make this discussion possible. And also, this is just the half of our event. We still have an offline event in Bali. So hopefully we will meet everyone there. As a closing remark, I will give it to Dr. Wayan, and then we can conclude our session for the whole online session for AURC. Dr. Wayan, please.
Okay, thank you, Dr. Diandra. Okay, I will say thank you very much for all of our panelists who are present start from the first week until now, who provide the assessment to the presenter. Actually, we have 7 cases already assessment from the panelists. And second, thank you very much for the presenter who had delivered the cases, and now we wait the result from the panelist assessment to determine who attends bring the cases in the main AURC program in UA Congress 2024 will be held from the 3rd until 5 September, especially in day 1 and day 2 AURC program. And also many thanks to the Professor Poncho, our boss, our chairman in UA Congress, and all of local committee. Of course, Dr. Sam for the advice and many advice for us for the successful, especially in this AURC pre-event series webinar. Okay, see you offline in the Bali at the September 2024.
Thank you, Dr. Wayan. Probably, is it possible for everybody here who is still attending to open their cameras so we can have a picture together as a, as a token of documentation for probably our future events. If everybody's still here, the attendees as well. Oh, can the attendee be, can they open their cameras, Dr. Missy? I don't think they can. Okay, webinar format. Okay, I'm so sorry. Probably all the panelists, we can if you're able to open your cameras, and then we can have a picture together. Oh, Dr. Sam, or probably we can switch everybody to join the panelists, and then they can open their cameras. Okay, is Dr. Sam here? Okay, we can please wait for a minute as we go through the settings first. Is Dr. Sam here, Dr. Missy? I'm not sure Dr. Sam is here. Oh, okay. Okay, thank you, Dr. Sam. Okay, so we'll have a, please, who's gonna be taking the pictures? Okay, please say, give us the mark.
Oh, I'm here. I'm here. Yep.
Okay, hi, Dr. Sam.
Hi.
Okay. Okay. Okay, everybody just smile, cheers, and then we can go one by one, I think. Please let us know if it's finished. Otherwise, we're going to be smiling for the next half an hour. Okay.
Picture 1, 2,
okay,
and 3. Okay, thank you so much.
Okay, thank you, everybody. See you
Thank
in
you.
Good day.
Bali. Bye. Take care.
Everybody.
Have a great Sunday.
Thank you, Dr.
Thank
Sam.
you. Thank you, Wayan, Deandra, everyone.